So I thought we can proceed this way, that I would like to ask everybody of you to give a brief introductory statement on what is the most important challenge in risk-adjusted prevention from your point of view. Then we will have some questions, and we will discuss briefly the questions within the panel, and then of course we are open for participation of you from the audience. From the audience. Okay, so maybe we start here with you, Carlos, as you have to leave soon. What is your, maybe a brief statement on the most important challenges?
Well, as I said in my talk, I think the most important challenge for me in screening programs is what types of cancer they are detecting. And I think that's particularly poignant in breast cancer, where one of the reasons why there is so much controversy is that a lot of the cancers that we diagnose in the screening program are low-risk tumors, and we probably are overdiagnosing low-risk tumors in DCIS, where then therapeutic intervention happens. But that's my view, that's my interpretation of the data. I think that screening programs can bring other advantages, and I think one of the ones that clearly it brought in the UK was the organization of multidisciplinary care that has completely revolutionized cancer care, originally in breast, but then extending to all cancers. And there is not a single cancer patient in the UK that is not managed with multidisciplinary care. And I think that that is a byproduct, if you want, of the screening program.
Maybe you continue from this advocacy side.
I mean, I would say it's different for colorectal cancer because you have benign preforms, which you can see in doing colonoscopy, and you can eliminate it, and cancer doesn't grow. So for this examination, it's not so necessary to know what type of cancer it is, because you can see it is cancer or it is cancer in the polyps. So that's a different case, I guess.
Thank you. For my part of view, I would think, given the extreme genetic heterogeneity that we are facing and that will increase even more in the future, I think we need to consolidate the cancer registries, and they should become a module of the familial cancer part, a module of the general cancer registries.
My proposal is that we are dealing with the enormous. Can you hear me? Okay. My proposal is that dealing with the emerging developments in genetic profiling, we do need definitely validated and evidence-based approaches before we implement screening, new screening programs, or before we recommend other preventive or newly prophylactic strategies like prophylactic operations, because it's not only important to know and characterize genetic mutation carriers and the clinical outcomes, but it's also very important for health care services to know what is what are the arguments and the justifications when we want to make clinical decisions, and how can we improve healthcare services and for the patients and special cohorts.
And in addition to what you said, Carlos, Caldas and Rita Schmutzler, it is necessary to train the doctors and the patients to understand what we, the doctors, are talking about, and with all the data, and what the patients have to decide. It is very important to increase the genetic literacy of all people who are involved in the process of decision-making for patients.
I think I would add that for studies involving the people with inherited syndromes, whether it's the BRCA, the Lynch, or FAP, we're at the point now where we need to consolidate the registries to develop appropriate clinical trials. Most of the trials I even showed you are really single-center design trials where 100, 150 maximum FAP or Lynch syndrome patients are enrolled and randomized. And really to be at a level of high-level evidence where you can see statistically significant findings, we need to be somewhat like the cardiologists where they have very strong networks of patients being enrolled in multiple sites, and this gets around some of the racial biases that occur by having a single center design or single state design.
Thank you, yes. Well, I guess there are a lot of unanswered scientific questions, but I suppose thinking specifically about stratified prevention, I think, there are some areas where we need a lot more data, I think. I think particularly on the rare variants, we're in a very kind of uncontrolled situation where a lot of bad testing is going on, and we need to try and get some grip on that. I think as far as more generally the stratified screening is concerned, I think it's more of a kind of logistic challenge to, most countries in Europe have an organized screening program, which the effect is rather limited, but it's well organized, so it's quite difficult to change a system which is already delivering something. So I think, it'd need a lot of education and probably a lot of political will to move to what would be a more rational solution of having screening based on risk rather than just having at the moment we have a kind of one size fits all. Nobody gets screened up to 50, then everybody gets screened. Well, that logically doesn't really make any sense, but it's going to require quite a bit of political will, I think, to change that.
I think the starting point is quite different for the major cancers we have been talking about this afternoon. For breast cancer, which is of course a very common cancer, the potential benefits of screening are, let me say, more modest compared to the potential benefits we have in colorectal cancer screening, and the dangers of over-screening and over-treatment are also greater. So I think here the main challenge actually is to come to a risk stratification as soon as possible. For colorectal cancer, I think the situation is different. Colorectal cancer is we not only have the potential of early detection, but we really have the potential for preventing this disease. And not only 20% or 30% of the disease, but 70 or 80% of colorectal cancers would be preventable. So I would say here the risk of over-screening, which does not have too many side effects, is not so bad. And the real challenge is to bring the screening to the population. And of course, we know the most effective way would be to do a colonoscopy in everybody. I think here we can work on finding less invasive alternatives to a colonoscopy that, like stool tests or sigmoidoscopy combined with stool tests or whatever, that might then be used along, perhaps with family history and genetic screening one day to stratify who would have to go to colonoscopy. But the first challenge here, and I think the most important one, would be to bring everybody to screening, and we could already now prevent the majority of these cancers.
Well, I guess I'd have to take a little bit of issue with that, because I think actually in the US, the population has kind of unreasonable expectations for screening. For example, in the US, people all still line up for prostate cancer screening, and they still have the expectation that breast cancer screening is going to prevent a substantial, many people believe that breast cancer screening will actually reduce their risk of developing disease. And in fact, they've just been diagnosed with a DCIS or a LCIS, and it has no adverse consequences probably. So I think it's actually the risk of screening. Although if there were a super sensitive and specific and cheap screening test for any of those, for colon cancer, I'd go that over colonoscopy. But I think it's the public's expectations that screening really is going to, in a very significant way, impact upon their morbidity and mortality. And unfortunately, same thing, again, the US example of lung cancer screening. So everybody's signing up for lung cancer screening. And everybody has lung nodules, at least in the US.
So I agree with you about the cost issue. I mean, so in the breast cancer field, you have this situation where you have MRI screening, which is probably more effective. I mean, certainly a lot more sensitive, but it's much more expensive, especially in the US, where it's really very much more expensive. So one major improvement would be to find cheaper ways of delivering MRI screening.
I would like to ask a question to you all. There are so many people. I mean, I'm talking about what I realize in Germany. So many people, so many families who don't know about their familial or hereditary risk. Isn't there a big challenge in educating doctors? That's a question to you all. And what do you do? What do you do, especially to educate doctors so that they can really advise the people what to do?
Maybe, Kerstin, you mentioned this already, improved genetic literacy. What are the, maybe you can say something about the efforts here.
We have started an initiative in the German Consortium for Hereditary Breast and Ovarian Cancer to improve the genetic literacy in gynecologists and working together with the German consortium. So we started with a workshop to inform the gynecologists about the risks for getting cancer with a specific mutation and how to communicate these risks to patients. And the second thing is that they are invited to come to hospitation in our center to see how we communicate with the patients to learn it. And after that, we certify these tools, the skills they learned for 2 years, and they have to come back to get the new information every year to refresh what they know and what they have to communicate.
And maybe importantly to say is this setting or construct is doctors are always very busy and they don't come to a clinic, to a hospitation if they are if they don't have time left. So what we did here is we closed contracts with at least some of the insurance funds that they get reimbursed for the counseling of their patients in order in case they do it correctly and they had the training beforehand. So that work now. It seems to work. And one other thing, what we found to be very effective, at least for breast cancer, and we try to translate this now to colon cancer, is that most of the doctors do not know our inclusion criteria, neither for breast cancer, Bethesda criteria, Amsterdam, the gynecology doctors should know them too, but they don't know. And there was at some time somebody from the medical association who was doing audits in the breast cancer centers approaching us and complaining that the inclusion criteria are too complicated. And then he came up with a checklist. There, you don't need to keep them in mind. You ask questions and you mark and make a score or so, and at the end it pops up if this patient fulfills the criteria or not. So you can do it without thinking. You can even have the patient fill it in. And so this was the easy tool. But when then this tool was integrated into the certification requirements for breast centers, that changed it all. Because at that time, the people that come for the audits, they checked if the checklist was filled in. And it was something for us like the Angelina Jolie effect. It was a similar increase, in the demand for counseling. So, what we can extract from this and can extrapolate is that we should think about such kind of implementation tools, facilitators to help doctors to get the knowledge for the patients. I think these are simple, very simple strategies and things, but they might be very effective. Yes, please.
So I think one opportunity that was unfortunately missed in the U.S., we feel, is as many hospitals have converted to electronic medical record systems. The two big ones in the U.S. are called Epic and Cerner, and you basically do all your notes, all the radiographic exams, colonoscopy, everything's fed into this kind of one master electronic record for each health system. It's not that there's a national or a statewide one, but the hope had been from people, I think, in our field that as physicians see patients, whether it's the primary care provider, the oncologist, they would be required to fill in family history, and that at the background, the electronic medical record system would be able to compute some kind of a risk estimate, even if it's very vague based on number of family members affected or Amsterdam criteria, some variation of this to make screen flash that this person deserves earlier colonoscopy or breast cancer screening or a referral to a genetics clinic. But none of the electronic medical record providers in the US have wanted to do this. Partly when we've talked to Epic, which is the one our health system uses, partly because of cost, and they feel it's very difficult to program in the type of code that they would have to in order to analyze a pedigree. That they tell us that a human being looking at a pedigree, you can very easily tell if multiple people are affected, but it's not so easy, I guess, for these codes to do it. I don't know if NHS or anything has a set electronic medical record that does anything even like that, forces you to have a family history inputted and then some even vague analysis?
I'm fairly sure not, no. I think the family history, detailed level of family history, that only really comes in at the clinical genetics level.
And also, for instance, Boadicea is an excellent tool. You cannot expect the general doctors to go into such detail and take the 3-generation pedigree. So that was the idea, to keep it more simple.
Well, one of the things we've been discussing, or maybe you're going to come on to this, is the idea that, well, two ideas. One is the idea that the patient might do that, collect that information themselves rather than waiting for getting to a clinical genetics and seeing a counsellor. So that would be one option. The other thing, which is there's some discussion about, is the idea that, I mean, people go to most people have some sort of health check at their GP to look for diabetes, get their blood pressure measured and so forth. In principle, there's no reason why that couldn't be combined with a genetic test for cancer. I mean, it's not a cost thing. It would be very cheap, in fact, to have a more comprehensive kind of genetic test at that point. A lot of issues there, but so rather than thinking about it at the sort of once somebody's already got a strong family history and so forth, you could think about it at an earlier stage when people are, as in most European countries at least, they have, contact with their family doctor.
Okay, this is already a very provocative statement, I guess. So, you wanted to say something concerning this?
So what would the genetic test be?
Well, for example, you could. Sorry.
What would the genetic test be?
So you could consider various things. I mean, you could have a test for which was just the SNP profiles for all the common diseases. I mean, that's more or less what 23andMe offered, right? But they didn't offer it very well, but actually it would have some value. Or you could have that plus the panel of genes. Now, at the point where we have good estimates, which we don't yet for some of them, but I mean, that would also not be difficult to do, technically.
Okay, so that's interesting, because
you might find things you don't want, so that's of course...
Actually, with respect to your statements, I wanted now to ask you what, I mean, because you all argued we need more data, you want to have evidence-based data, we need now new studies. This morning session for the sporadic cancer, it was the same. We need new clinical studies. I was actually going to ask you how these new studies should look like, but now we will jump first to what you said, as this is the next question. Are we really ready to offer genetic testing in the general population, like Mary Claire King argues for the BRCA1/2 analysis as well? Now, let's stick with the high-risk genes, because this is easier, actually, before we go to the whole bunch of low-risk and moderate-risk genes. What is your opinion, and what would you say is a prerequisite if you don't feel that this is already the time to go? Then we start with you now.
I was just going to mention that, would you even suggest, what would you do with that information for diseases for which there was no action?
Want to answer immediately? Or?
Well, perhaps you would restrict it to those diseases where there was some action. So for colorectal cancer, there clearly is a very effective intervention. I think if it was me, I think I might want to do that. I mean, for other diseases, maybe not.
Maybe I would also like the audience to comment on this. What would you suggest, or are there ideas? Should we start with a direct-to-consumer test or something like this, or a gene panel to identify elevated risks in the population?
From my point of view, it's very problematic to propose such a general testing of genetic profiling in the general population, because you first have to ask what's the reason for, and for what purpose, what is intended. And then it's not only the testing, but you also have to think about the justification, the substantial justification on medical, ethical, social, and human issues. And we haven't answered these complex questions, and therefore I think we are not ready to go for that.
I think we really should make a distinction here between consulting in relatives of cancer patients or in high-risk groups that we know, or there are some suggestion that they are at high risk, and rather, if we talk about population-based screening, I would think that we are still far from using these tests, because I think this, first of all, our knowledge about the role of these risk scores together with all the other risk factors is probably too limited yet. And the second point is that we would need so much good genetic consulting along with this testing, for which I don't think we have the resources.
I think the example that the two of us spoke about is in the setting of multi-gene panel testing now, we're finding lots of patients referred for a mutation in the CDH1 gene, which is associated with a hereditary diffuse gastric cancer. So this is a major cancer predisposition gene, autosomal dominant inheritance, and from the studies that had occurred in the past, remember they were referral bias studies, meaning families that fit having lots of hereditary gastric cancers. You found a CDH1 mutation, the recommendation would be you would do a prophylactic gastrectomy. Now in the world of multi-panel testing or multi-gene panel testing, you find families where there's no gastric cancer, but the gene mutation exists. What do you recommend to them? So what I'm bringing up is we've created a Pandora's box with these multi-gene panel testing. We've found results now in the population that is being screened because of some history of breast cancer, or because these genes, CDH1 for example, are part of these panels that you're running for colon cancer or breast cancer, but you don't know what to do with the results because the family history doesn't fit anymore.
Well, I think that's right, but I think that's the fault of the system for ordering the test in that way. I mean, that just seems to me that's bad medicine to order tests where you wouldn't know what to do with the result. So I think that's a little different from the argument about whether you should have population screening. But I absolutely agree that we need a lot better data on the risks associated with all the genes on the panel test. So that's an important part of research we need to do. I think there's a question.
Yes, Dr. Schröck. So where is the microphone?
Okay. Thank you very much. I would like to know what you think about, there are more than these cancer syndromes. We have about 100 familial cancer syndromes, and if you work with pheochromocytoma or paraganglioma or any other, like you just mentioned, CDH1, gastric cancer, prostate cancer, and so on, there could be ways similar to HPOC or HNPCC to design diagnostics, to design risk estimation, to design criteria, who to enclose. And I think there are many families out. We actually find, we have 300 panels done in families, and we find first de novo P53 mutations, de novo P10 mutations, and we have nothing in place for them to do any surveillance for the families. We really struggle with the health insurance companies, and I think it's time now to do these tests in certain families for all the other familial cancer syndromes. Not for the overall population, of course, but we have many families which have not such a good structure as our HBOC or HNPCC families, and I think it's time now to do so.
Mm-hmm. Does anybody want to comment on this? So you suggest starting with the gene panels, actually. Yeah, and especially for the high-risk families, yeah. What is your opinion on that, or how is it done in the States or in the UK? A gene panel analysis, is this already introduced? With the genes you mentioned, ones that are already associated?
I think the situation is, in the UK anyway, is that a few centres are using some sort of panel testing, but it's not in the way it's used in the US. My sense is you order a panel and you get all the results back, and then you have to worry about what it all means. In the UK, it's more it's a bit more selective. So they may use the panel as a way of doing the test, but they're only reporting back on a subset of genes where the evidence is reliable. Which, to me, that seems a bit more rational. But it is, I mean, even for so for example, in Australia, I think PALB2 testing is part of clinical management now, but it's not elsewhere. In the Netherlands, CHEK2 testing is part of clinical management, but it isn't elsewhere. So the situation is highly variable. Yeah.
Very heterogeneous right now. I've just seen the new NCCN guideline. They recommend even mastectomy in case of a PALB2 mutation, a deleterious one. So this is the first guideline that supports such a preventive option.
So I think in the US, one of the problems that's been encountered with panel testing is that companies, specifically Myriad, to pick on them, in at least some US states has gone for direct-to-consumer marketing of the test, and that creates if the patient feels their family history is strong enough, is going for whatever genetic test, going to their family doctor and then sending off the buccal swab or blood test, and that can create problems as just like CDH1, but even P53, if it doesn't fit in the context of a family with a set syndrome of cancers, what do you encourage that person to do? BRCA1, same thing. If you found a mutation but there was, for some reason, no breast cancers in that family, would you really recommend mastectomy or even going down the MRI line? Like, how much risk would you take? Is the more investigations you do, and we've seen this with lung cancer screening, the more things you find abnormal and that you end up doing biopsies, and you will have some morbidity, maybe not mortality, but morbidity from the more procedures and the more things you look for. We have pushed, and this is not universal, but we have pushed in our cancer center and at Intermountain Healthcare's cancer center that genetic testing only be performed by the genetic clinic, the genetics clinic. So that forces even the oncologists, the primary care doctors, the obstetricians to refer anyone they want genetic testing in to see a geneticist and a genetic counselor, and streamline where the data is coming back to as well. I think that's been the harder thing is if you get a clearly deleterious mutation, you can usually look up a guideline and recommend what to do. But if you have a variant of unknown significance or a family history that really isn't consistent with the genetic finding, you usually need some kind of help.
Yeah, I thank you very much that you pointed out this so clearly that that with the gene panel analysis now the familial background becomes so important, and a TP53 mutation might not indicate a Li-Fraumeni syndrome family, so that's what we are dealing with right now. Yes, and there's a question over there, or a comment?
Sorry for throwing a word into the discussion that has not yet been mentioned. A couple of months ago, I was made aware by Focus Online of the results of a Danish group screening women for breast cancer, metabolic phenotyping, and with a likelihood of 80%, they were able to predict the outbreak of breast cancer in 5 years period, just by identifying the metabolic phenotype. We know from other diseases, just by identifying the metabolic phenotype, like by inborn errors of metabolism, that you just look at the phenotype and not at the genotype for predicting the outbreak of a disease. And we know that also from some enzymes in Parkinson, where you can identify the phenotype of a mutated enzyme by just doing a metabolic analysis. So and I read this article in Metabolomics later on Focus Online. That was a kind of population screening. I was wondering, with a likelihood of 80%, 5 years, if this could not be worthwhile thinking about that the genotype alone may not result in a high likelihood of prediction.
Absolutely, I think we all agree in that, and maybe some of you want to comment, maybe Dr. Brenner, on this study that was a result from a large epidemiologic study. Doug is involved in the additional analysis of non-genetic modifiers. Maybe you want to comment on this.
I do not know this specific study, I have to say, but I mean, this would be nothing unusual, and we mostly use non-genetic approaches to screening so far in many fields, like in colorectal cancer screening. We work a lot with the fecal occult blood test or the NeuroFITs, which are, of course, entirely non-genetic tests, if you wish. So this is, of course, this is a discussion round now that focused on genetics, but so far, or overall in practice for screening, genetics is, of course, just one of the options.
And maybe, thank you. Maybe you want to say something about the non-genetic risk factors?
Yeah, well, certainly in terms of, I guess there's two slightly different things. One is risk prediction, and that's for sure these other risk factors may be important, including other things you can measure in blood. I'm a little bit skeptical about the specific metabolomics test. I think I can sort of remember it. It seems a bit too good to be true to me, but for sure.
Then coming back to the translation into the clinic. I mean, I think there is an agreement that somehow we have to deal with the option now on the possibility of gene panel analysis. And the question is how to introduce and how to translate this into the clinic. So, Doug, you showed slides and the data and definitions by the NICE guideline, what is high risk, what is moderate risk. So there are these sharp cuts, 30%, 70 to 30%, over 30%. So we face already the problematic or the situation, what is with a woman that is at risk 31 or at risk 90 29, can we really have the sharp cutoffs? Who is supposed to do them on the basis of what data and evidence, and maybe also normative, ethical, legal considerations? And can we open up some kind of corridor for patients to be involved in the decision making here?
Yeah.
Whoever wants to comment on that.
A lot of questions there. I mean, I guess one thing to say is that the guidelines are guidelines. They're not. They don't, as far as I know, they don't have any implications. Maybe they have some implications in terms of reimbursement. But so what's called the high-risk group, which I agree is not, that's not, at least most aspects of that aren't evidence-based either, except for the MRI screening, which I think there is quite good evidence for that. But, in that group, there's a sort of general expectation that women would be offered the option of prophylactic surgery, but only a proportion would take it. They would probably be offered MRI screening, but only a proportion would take it. So it's not it seems to me it's not, it's a useful classification, but it isn't a very hard and fast one.
And maybe Dr. Zimmer, do you want to say something about your point of view concerning cutoffs and normative decisions?
I think the risk discussion is an empirical and scientific discussion and has to be funded by clinical and empirical and evidence-based knowledge about this. I don't think that the Federal Joint Committee will say the cutoff is 10%, 20% or something like that, because you have to keep in mind not only the risk level, but as well the consequences about this risk in clinical perspective, but as well in the perspective what you want to do and to improve for the patient or for the healthy person under risk. Therefore, I think that's an interdisciplinary empirical discussion which has to be solved not by the legal or the judgment of the Federal Joint Committee.
So then coming back to the requirements for gaining evidence here, what kind of studies can we think of and study designs to gain this evidence? I would expect that RCTs are not possible, not considering the preventive measures, nor considering genotype-phenotype correlations with respect to this extreme genetic heterogeneity. So how to gain this evidence? I mean, one idea what we discussed before was already, going via the cancer registries, the familial cancer registries, documenting and having large cohort studies to gain the evidence. Would this be a way to go? I've talked already, or we had discussions also with our colleagues from the EU levels that commented, and that were very questionable and wondering if we really can manage this huge effort, and because it's really a huge logistic challenge then. Should we go for that?
I think so. I think especially for evidence for many of the prophylactic surgeries and chemo prevention that we're talking about, since they can have implications for the person's lifetime, or it could be a medication they're on for lifetime to prevent cancer from occurring. We do need well-designed RCTs that could really only be done within a consortium. I think it's a different question how to get them funded. That has not been as easy to do as one would have thought. CCFR has done some of it, but even they have had trouble, I think, more recently with renewals.
It's for renewals for us, but I did want to just follow up a little off. You said that you didn't think that RCTs were possible?
Aren't really possible.
To answer the question about whether there's enough evidence?
To answer the question concerning, for instance, the uptake of preventive measures in case of prophylactic surgery, you will not be able. It might be. I think I know what you want to say. It might be different if you have a prospective trial on chemoprevention. Right. This, of course, is a way to go. That's for sure. But with respect to the low-risk genes to come, with the extreme genetic heterogeneity, what are you going to do with this?
I think there are, of course, RCTs have their place in every field of medicine, but in the field of prevention or cancer prevention by screening, they really also have their limitations. And I just give one example of. There's now an ongoing RCT on screening colonoscopy ongoing in the Nordic countries. We know by now that colorectal cancer takes probably not only 10 but 20 or 30 years to develop from the early lesion, from the adenomas to the full development of cancer. So we can design new trials like that if we are prepared to wait 20 or 30 years for the results. If we now go on or want to do more sophisticated screening, let's say implement genetic stratification in that screening, and we would want to test that by an RCT, would have to wait again 20 or 30 years for the results, which I think we should not do. So we really have to find alternatives for that. For example, go into screening populations right now. For example, in Germany, where we have a screening colonoscopy as a screening offer, go to these people, look at their risk factors, look at their genetics, see how well we could predict to find anything, especially the relevant precursors of colorectal cancer in these patients, and then we can go on and calculate, well, how effective would it be to stratify our screening efforts by this risk factor information or by the genetic information, which is something you can do within, let's say, a few years and would not take several decades.
I agree this is a way to go, and we should go whenever it's possible. However, the argument against it is that all of the screening programs start when actually most of the familial cases, at least the severe cases, are already affected. So this is one way, but we still need to have to think about gaining evidence for the younger ones, and not for the ones that are eligible for the mammography and the colonoscopy screening.
But you could do the same things. I mean, those people with a family risk, they are advised to go to colonoscopy or whatever much earlier, as we have heard here, and you could do the same things within these groups when they come to their current routine or routinely recommended colonoscopies, for example.
Okay. You wanted to say something? Comment on it? Yes, there's a question there, or comment?
For all people, or just because it depends to the health insurance, or they are systematic for all individuals in Europe? How is the situation? The screenings.
What's the genetic screening or screening for
genetic
cancer?
Screening, like colonoscopy, for example, it's systematic for. It depends to the health insurance, or it's.
Yeah. Yeah, I can say so. I think all over our countries, mammography screening is a screening program, meanwhile, in all countries, I guess. Colonoscopy
I don't think so.
is...
It depends to the health insurance, I think.
Beg your pardon?
I think it depends to the health insurance, what type of health insurance you have, and I think like that, if it is, the situation is like that, you will have people who have screening, and there will be, for example, diagnosed at stage 1, and they will have better prognosis. And people maybe who doesn't have access to this screening, they will be diagnosed later, and it will affect the prognosis. I don't know.
That's right. I can say for Germany we have the screening, for several other countries, and I know from the
UK, US, Germany.
From the EU puts a lot of effort in having in getting here standardization all over Europe to make sure that the screening offer and modalities will reach the population. It might not be the case yet in all of the European countries, but they are very aware to bring this service to the patients and to the women on the population?
There are inequalities in screening, even if insurance isn't an issue. So in the US, Medicare, so once people turn 65, people have access to Medicare insurance, and screening is fully covered. The colonoscopy.
It depends.
Well, colonoscopy for colorectal cancer screening is covered. Mammography within the age group would be covered. Below that, between 50 and 65, it would be insurance dependent, though in the US now there is a fail-safe system where everyone can theoretically get insurance with government subsidies, regardless of income level. So again, theoretically, you can provide colon cancer screening as an example, or mammography to the entire population. But there are studies from Oregon that were done that showed even if you take insurance out of the mix, meaning everybody in this cohort of patients that they followed had access to colonoscopy, there was differential uptake. And some of that may be socioeconomic, some of it may be race-based. The outcome of that study was basically there was a feeling that physicians were less likely to recommend colonoscopy screening to people who are of African American descent than whites. So insurance was not an issue. There were other biases.
Yeah.
So.
Thank you very much. So I guess we are coming to an end now. Just some closing remarks. I think we all agree that we have to take the challenge to introduce the new gene panel analysis that have become possible right now. We don't want it to leave it just to the companies out there, but we all agreed that we want to gain evidence. We have to gain evidence in order to to allow these gene panels, or to allow it to extract preventive measures by them. We have to go for the clinical trials in prevention as soon as we are confident with a gene panel analysis, or with a gene panel that hopefully will end up for the main tumor entities like breast and colon cancer to have a comprehensive panel within the next few years. At least there are huge studies funded by the EU ongoing to establish such panels. Yes, and I think it's to me now just to thank all of you for your participation, for the interesting discussion, for your questions and participation, and I want to close the session now and wish all of you a nice evening.
Can just quickly grab the word from you. I think we've talked so much about colon cancer prevention. I think it's time you had your vegetables, actually. Thank you very much.